We're going to go ahead and get started today. This is our final session of the summit today, and we have two pharmacists from Northwestern Medicine. Our first presenter will be Erin Weslander, who is a board-certified infectious disease pharmacist and pharmacy practice coordinator in antimicrobial stewardship at Northwestern Memorial Hospital in Chicago. She obtained her Doctor of Pharmacy from University of Minnesota College of Pharmacy. She's also completed her PGY1 and PGY2 in infectious disease at University of Minnesota Medical Center. She's passionate about antimicrobial stewardship, One Health, quality improvement, optimizing educational resources and designs. Additionally, we have Christie Bertram, also another pharmacist from Northwestern, and she is an infectious disease and antimicrobial stewardship clinical pharmacist at Northwestern Memorial Hospital in Chicago, and as an adjunct assistant professor at Rosalind Franklin University College of Pharmacy. She obtained her Doctor of Pharmacy at Butler University and completed a PGY1 and PGY2 in infectious disease at Northwestern Memorial Hospital and Midwestern University Chicago College of Pharmacy. She's passionate about antimicrobial stewardship, treatment of multi-drug resistant infections, pharmacy education, antibiotic allergies, and as well as microbiology and rapid diagnostic testing. And I always forget to introduce myself, but I'm Star Cervantes. I am the antimicrobial stewardship infectious disease pharmacist for the City of Chicago Department of Public Health. And I'll let them take it over.
Thank you so much. All right, everyone, thank you for sticking it out with us. We know it is the last session of the day, so we'll only judge you a little bit if you walk out of here early. But we are talking about a very broad topic today, the treatment of gram-negative infections. And we figured since it was the last session of the day, we were just going to go very broadly, cover a lot of topics to keep you all interested. Just wanted to point out, neither myself or Dr. Weslander have any disclosures. But we'll be focusing on three major objectives today. First, we'll talk about carbapenem resistance in Enterobacterales species and recommend appropriate treatment regimens for those. We'll then jump into Pseudomonas resistance and talk about how we can overcome some of those resistance mechanisms with our treatment. And we'll touch specifically on evidence supporting combination therapy or lack thereof. And then we'll finalize our presentation today by comparing clinical outcomes for treatment durations for gram-negative infections, including bacteremia and pyelonephritis. So just wanted to start out with CRE here. So this is one of our CDC antimicrobial threats, and it is on the urgent threat report list, meaning this is one of the most intense infections that we really need to find better treatment for. Just wanted to see by a show of hands, how many of you all have encountered a carbapenem resistant organism in your practice? Okay, so about half the room. Not to be the bearer of bad news, but for the rest of you, it's coming soon, so you do need to be prepared. Carbapenem resistant Enterobacterales infections account for more than 13,000 nosocomial infections annually and contribute to greater than 1,000 deaths. And this number will continue to rise as, unfortunately, resistance rises across the country and the world. I put together this timeline to really demonstrate how gram-negative resistance has been evolving over time. And I think it has a really clear message here. So you can see back in the early 1960s, ampicillin came to market. However, a couple years after is when we first started seeing resistance to ampicillin, and that was with the development of TEM1 beta-lactamases, particularly in the E. coli species. We then had our cephalosporins come on market in the 1970s, 1980s, and then shortly after that, we had ESBL that emerged in 1988. What I think is really concerning is when you jump to the end of this timeline here. So that is when, in 2009, we start to see pan-resistant Enterobacterales species to all of the antimicrobials that are available on market. And luckily, we had a couple new antibiotics that were recently approved in the 2010s. Ceftazidime avibactam is one that we're going to highlight today. That came out in 2015. And what's really concerning is there are not just a couple years until we see resistance develop like we did in the past, but that exact same year, as soon as this drug came on market, we were starting to see isolates that were resistant to ceftazidime avibactam. So resistance is really a major problem, and it is continuing to develop very, very quickly. Particularly speaking about carbapenem resistance, there are 4 major mechanisms, but we'll be focusing on the last one here today. But carbapenem resistance can occur in Enterobacterales due to upregulated expression of efflux pumps. So once the drug gets into the bacterial cell, just gets pumped right back out and is no longer effective. We've also seen reduction in outer membrane permeability, so problems of the antibiotic getting into the cell. And then we also have a lot of gram-negative species that have overproduction of AMP-C or other ESBL enzymes that make it very challenging for those antibiotics to work. And then finally, we have our carbapenemase enzymes, which are particular enzymes that gram-negative bacteria produce that hydrolyze our carbapenem antibiotics, which up until a couple years ago, we thought of as our broadest spectrum, strongest antibiotics on the market. And carbapenemase production actually accounts for the majority of CRE in the United States, so 35 to 59%. Here's a description and a breakdown of the different types of carbapenemase enzymes that are most prevalent and have been identified in the United States in particular. We have them spread over all 4 classes of the Ambler classification, which is the most common way we describe beta-lactamase enzymes. In class A, we have KPC, which stands for Klebsiella pneumoniae carbapenemase. And this one is a little bit of a misnomer, although it was first identified in the Klebsiella pneumonia species. It can actually be present across all Enterobacterales. We then have our class B, which are probably the most scary to anyone that you talk to. These are our metallo-beta-lactamases. They include our Verona integron-encoded metallo-beta-lactamase, our imipenem hydrolyzing metallo-beta-lactamase, and our New Delhi metallo-beta-lactamase. And the reason why these are so scary is because we really have limited treatment options targeted at these drugs. These organisms. So these are a really important class here that we are starting to see increase in prevalence in the United States that we need to keep our eye on. And then finally in class D, we have our oxacillinases, which are also a type of carbapenemase. At the bottom, you can see the prevalence here in the United States, and KPC by far is the most common enzyme that accounts for the carbapenem resistance. So about 86 to 92% of our carbapenemase producers in the US are because of KPC. However, NDM is now at number 2, which again is very concerning because these are probably the most challenging to treat. And then we have our others that are also continuing to increase in prevalence as well. So here's a typical susceptibility report of what you may encounter when you see a carbapenem-resistant Enterobacterales. And this is very scary. You can see, for those of you in the back that may not be able to see it as well, everything in the red box there is resistant. And those include all of your beta-lactam antibiotics that are routinely testing for susceptibility in the microbiology lab. We have other antibiotics on there that may or may not remain susceptible depending on certain mechanisms of resistance. And in cases where they are susceptible, that's great. However, not every situation will remain susceptible. All right, so we're going to be talking about some of the newer antibiotics that are recommended as first-line therapy for treatment of CRE. As you can see, all of these are fairly new. 2015, I guess, is not that new anymore, but we have Cefidoracol, which came out in 2019, so just a couple years ago, and we're hoping to continue to add to this list. But I just wanted to highlight the differences in coverage here. So ceftazidime avibactam, or Abicaz, is going to be one of the broader agents in coverage because it does cover Class A as well as Class D carbapenemases. Meropenem vaborbactam covers Class A, and same for imipenem cilistatin relebactam. Cefidoracol, on the other hand, is the broadest on the list in that it has activity for Ambler's Class A, B, and D. The place in therapy for these agents is kind of murky at this time. Since they are newer, there's not as much clinical data. However, we are accumulating more and more, so we have started to define niches in therapy for all of these agents. For ceftazidime avibactam, it is preferred for CRE infection, and it also is preferred for metallo-beta-lactamases in combination with aztreonam, and we'll get into this a little bit deeper. Meropenem vaborbactam is most preferred for KPC. However, it is important to note that it does not offer any additional activity as compared to meropenem for multi-drug resistant Pseudomonas infections. Imipenem relebactam can also be preferred agent for CRE, And ceftriaxone is an alternative for CRE as well, including our metallo-beta-lactamases. However, it is important to note that in the package insert, the FDA has put on a warning for ceftriaxone for higher all-cause mortality, particularly in critically ill patients that you're using this agent for to treat a carbapenem-resistant infection. And the cause of this increased mortality is not entirely clear. So I think it's still important to recognize that this warning is in place. However, in the credible CR study that really showed this higher all-cause mortality, most of it was associated with those carbapenem-resistant Acinetobacter infections as opposed to our Enterobacterales species, but definitely something to still keep an eye on. All right, so let's move into our treatment. And this was recommended in the IDSA gram-negative treatment guidelines. There was an update that just came out last week. So myself and Erin read all 175 pages for you over the weekend and tried to summarize it here. So you don't have to do that this week. But definitely recommend taking a close look at it when you get a chance. But for the treatment of CRE, urinary tract infections, we really break it down between whether we're experiencing an uncomplicated cystitis or a pyelonephritis or a complicated urinary tract infection. So preferred therapies for uncomplicated cystitis include really our non-beta-lactam agents. So when you can, go ahead and use that fluoroquinolone, trimethoprim, sulfamethoxazole, and nitrofurantoin. And that's really reserving some of these newer, broader spectrum beta-lactams for when we really need them. We know most patients with uncomplicated cystitis probably don't even need antibiotic therapy to begin with. So we don't want to be exposing them to these broader agents when it's really not necessary. As an alternative, the guidelines do recommend considering some of these newer agents if you do have treatment failure to your preferred first line or you have contraindications. And a single dose aminoglycoside is also recommended here. The really cool thing about aminoglycosides is they concentrate very highly in the urine. So especially for uncomplicated cystitis, you can just give one dose of the drug and that will be enough to kill off most of the bacteria that are there. For CRE in particular, there's some data suggesting that amikacin and plazomicin have higher efficacy. However, any drug that comes back susceptible, whether it be tobramycin, gentamicin, because of the high urinary concentrations, it should still be efficacious. When we move to pyelonephritis or complicated urinary tract infections, this is where the guidelines shift a little bit in their recommendations. And this is because this is a more systemic infection that we do need to take a little bit more seriously because of downstream complications such as secondary bacteremias. So our preferred therapies here, if susceptible, you can use your fluoroquinolone or trimethoprim sulfamethoxazole. But here's where our newer agents are really moved into that preferred category. And in terms of all alternatives, aminoglycoside here again, you can use that due to the high urinary concentrations. However, in this case, you'll probably need to go with a little bit more of a full course of treatment. So a 7-day course up to a 14-day course, and this should be dosed by therapeutic drug monitoring. And when we move to more systemic CRE infections, so bacteremia, pneumonia, bone and joint infections, et cetera, again, we see that our newer agents are preferred first-line therapies. We have ceftazidime avibactam, meropenem varebactam, and imipenem relebactam up top. Ceftriaxone is an alternative here. This is partly due to that warning for mortality, but really the priority reason why ceftriaxone is an alternative is because we really just want to reserve its place in therapy for when we really need it. So again, it is our broadest agent, covers most Ambler classes. So really reserving it in cases where our other preferred therapies are resistant. And then as another alternative here, we have tigecycline or ribociclib. The caveat and important to note is that you should not be using these for bloodstream infections or urinary tract infections. And that is because they have high tissue distribution and will not stay in that area. They will not stay in the blood, they will not stay in the urine, so you will likely have treatment failure. And if you take anything away from this presentation, I want you to star this, avoid polymyxins. So polymyxins used to be our mainstay of therapy in combination with many other agents for treatment of CRE. However, observational and clinical data has shown that it does increase mortality in these patients with gram-negative resistant infections, and we see excess nephrotoxicity versus comparator regimens. The CLSI also eliminated the susceptible breakpoint for polymyxin because of this concern about clinical efficacy and due to concerns about the accuracy of susceptibility testing. So avoid polymyxins, danger, increased mortality, kidney damage, do not use, since we do have these other agents available. All right, so now moving into specific treatment recommendations for certain carbapenemases. This is very important, and not a whole lot of microbiology labs are currently doing this, but how many of you guys know if your microbiology lab is currently performing carbapenemase testing? So telling you, instead of just showing you that meropenem or ertapenem or imipenem is resistant, actually telling you which specific gene and enzyme was detected. Show of hands. Okay, so not very many, probably about a third of the room. The new guidelines recommend that every single microbiology lab perform carbapenemase testing because it is important in which treatment we choose for our patients. So if KPC is detected, the guidelines do slightly give preference to meropenem vaborbactam over ceftazidime avibactam, and then that has slight preference over imipenem relebactam. And although there is limited data comparing the efficacy between these newer agents, there was one observational study who evaluated about 140 patients who received meropenem vaborbactam versus ceftazidime avibactam for a CRE infection. And it showed that for clinical cure, we had 85% in the meropenem vaborbactam group and only 61% in the ceftazidime avibactam group. And that was limited to those isolates that were confirmed as susceptible to those agents. And then additionally, we did see higher resistance rates with ceftazidime avibactam compared to meropenem vaborbactam. So our differences in resistance here is estimated to be about 10 to 20% resistance with ceftazidime avibactam after a single course versus 0 to 3% with meropenem vaborbactam. And the guidelines do recommend that imipenem relebactam, although a preferred agent, you have a little bit less of a preference for, just because there's less clinical data as it is one of the newer agents compared to the others. An alternative here is cefiderocol. However, there are no studies available comparing it to our other preferred treatments. And since we know that cefiderocol is a little bit broader in spectrum in terms of its ambler coverage, that is why cefiderocol is listed as an alternative. Moving on into our metallobatylactamases. So these again are our scary ones, so very limited treatment options. Our NDM, VIM, and IMP. Our preferred therapy is actually going to be a combination of ceftazidime avibactam plus aztreonam. This is very important because chances are if you just give ceftazidime avibactam alone, you will not see efficacy with that agent. And that is because most of these gram-negative organisms co-produce and co-harbor many other resistant gram-negative enzymes, including ESBLs and OXA enzymes. So the reason why we have to give them both in combination is because the aztreonam is actually stable to kill that MBL. However, all those other ESBLs, OXA enzymes are going to break down and hydrolyze aztreonam. So we protect it by using avibactam. So by giving the two together, avibactam is inhibiting those other ESBLs, OXA enzymes, allowing aztreonam to do its job to kill off that MBL. Very important to administer them at the same time in order to have maximal efficacy. And the guidelines do recommend extended infusion therapy for these agents. And the new guideline update did have a slight preference for aztreonam every 6 hours, which is the difference because usually that drug is administered every 8 hours. And then cefiderocol monotherapy can also be another preferred option. However, there are clinical outcomes data that is lacking to really compare these two head to head. And then we have OXA48. Unfortunately, we only have one preferred therapy here, that is ceftazidime avibactam. An alternative would be cefiderocol or a tetracycline derivative here. But there is less clinical data with cefiderocol, so that is why that is listed as an alternative. And again, you want to avoid your tetracycline derivatives in bloodstream infections and urinary tract infections. And of note, again, this is going to be our class D for our carbapenemases. So meropenem vaborbactam and imipenem relebactam have limited to no activity. All right, so just wanted to start moving into a couple cases here. So this first case you can see is an ESBL positive Klebsiella pneumonia isolate. Our microbiology lab does perform carbapenemase testing and told us that the organism does produce the KPC carbapenemase. So based on these susceptibility results and what we just talked about, what would be your preferred antibiotic treatment option? Either ceftazidime avibactam, imipenem relebactam, meropenem vaborbactam, or ceftriaxone. So show of hands for A, ceftazidime avibactam, B, imipenem relebactam, C, meropenem vaborbactam, or D, ceftriaxone. Good. So this one, I agree with the majority here. Meropenem vaborbactam, again, shows to potentially have a little bit more potent activity for the KPC enzyme with less development of resistance. However, ceftazidime avibactam may be a viable option, imipenem relebactam as well, and even ceftriaxone as an alternative if your patient has contraindications or if you don't have all of these agents on your formulary. But then in this particular example, this was pulled from a real patient case. You'll notice here that our ceftazidime avibactam MIC is elevated at 8. So although still susceptible, it is showing a little bit higher resistance than our meropenem vaborbactam here. Then we have our second clinical case. So this is, again, an ESBL positive Klebsiella pneumonia. However, our microbiology lab told us that this organism actually produces the NDM carbapenemase. So you can see a very scary looking resistance pattern on that susceptibility report. So we have, again, our antibiotic treatments, either ceftazidime avibactam, imipenem relebactam, meropenem vaborbactam, or the combination of ceftazidime avibactam plus aztreonam. Show of hands for A, ceftazidime avibactam, B, imipenem relebactam, C, meropenem vaborbactam, or D, our combination therapy. Good. So again, our MBLs are very scary. We only have really 2 preferred therapies, either ceftriaxone monotherapy or a combination of ceftazidime avibactam plus aztreonam. Always remember to give these together, extended infusion at the same time. And just wanted to briefly mention some formulary considerations. All of these drugs are fairly expensive compared to other antibiotics that we routinely use, anywhere from $350 to about $550 per dose. So it may not be feasible for you to add all of these agents onto your hospital formulary. So I think, in my opinion, ceftazidime avibactam should be the priority, as it does have activity for all of our carbapenemases, the KPC, as well as oxacillinases. And you can use it, again, for that class B, the metallobetalactamases, in combination with aztreonam. However, it does have, has been shown to have the highest rates of resistance development so far. This may be because it's kind of one of the older ones that has been on the market. So we may start to see increased resistance with the others as well. But in clinical studies, we do see resistance developing, particularly after patients have received a course of it. And then some of the other nice to haves, again, meropenem vaborbactam, very active for KPC, which is the predominant carbapenemase in the United States. However, it does lack activity for some of those other resistance genes. Imipenem relebactam, it is active for CRE, but robust clinical data is really lacking. And ceftriaxone does have activity for all the carbapenemases, including our metallobetalactamases, but it does have that FDA warning for mortality that we likely need more data to fully assess. And you may encounter challenges with susceptibility testing for ceftriaxone, as due to its mechanism of action and structure, it requires special iron depleted media for susceptibility testing. So may have to be a send out for your microbiology lab. With that, I will transition over to Erin, who will jump into Pseudomonas. Thanks.
All right. We're going to try to cover every other gram-negative except CRE in the next 30 minutes. So we're going to start out with Pseudomonas. So Christie covered CRE, so E. coli, Klebsiella, probably the most common. Pseudomonas is another big problem. Have you guys seen carbapenem-resistant Pseudomonas? Maybe if you haven't seen the scary, NDM. So this is kind of tricky resistance. If you see carbapenem resistance, it doesn't mean you can't use other agents that are susceptible. So this is very different than the beta-lactams for Enterobacterales, like E. coli. because you can use something like cefepime even if meropenem is resistant. So this is on our website, adsp.nm.org, or you can check out the SIDP Breakpoints episode on Pseudomonas resistance. So there's a few things to keep in mind. Can the drug get into the cell? So that's where you're really going to see your carbapenem resistance is OPRD is probably the biggest one that is a porin channel mutation. So it just can't enter the cell. So you're not going to have issues with breaking down the antibiotics like cefepime because they can get into the cell and it's not the same resistance mechanism. So the mechanisms of resistance are really important for Pseudomonas in particular to consider which agent you can use depending on the susceptibility pattern. And you'll see there's some beta-lactamases, but unlike everything Christie just talked about, those are really uncommon to see something like KPC or NDM. They're just generally not carried in Pseudomonas. AMP-C is really the biggest beta-lactamase enzyme, which can be overcome pretty easily with a lot of our antibiotics. So it's a lot more complicated, and you're going to have to think about the newer agents a little bit differently if you're looking at Pseudomonas. So here's an example. So we've got a Pseudomonas here, and you can see the big thing is really the carbapenems. So we just talked about meropenem vaerbacterium being great for CRE, for KPC. Is this going to help with this patient? And anyone? Yes, no? No. Okay, great. And it's because of the mechanism. So it doesn't carry KPC. That's not where it comes from. As again, a reminder, the big thing is the porin channel mutation. So the OPRD is where we see meropenem, imipenem resistance, which is exactly what we see in this isolate. So cefepime should be fine. Any of the other beta-lactams should be fine, but wouldn't want to use carbapenems. Okay. So do we need combination therapy? So the HAPVAP guidelines from 2016 recommended to do combination therapy if your center has greater than 10% resistance to Pseudomonas. So do you guys at your centers have more than 10% resistance to Pseudomonas for first-line agents like cefepime and piptazo? Yeah. Okay. Several people are nodding their heads. So we're, 10%-ish. So technically we may want to consider using 2 agents. So do you double cover for Pseudomonas up front? No. Okay, very good. So the HAPVAC guidelines recommend MRSA coverage, anti-pseudomonal beta-lactam, and they recommend to add on a fluoroquinolone or an aminoglycoside or a polymyxin. So I think the key here is that this is from 2016. And so I think we have more information that you probably don't need to double cover it. So this was, if you have good agents, if you're really worried about Pseudomonas resistance, using a broader agent that has better coverage to get you below the 10% mark. Or if you're lucky and you have good cefepime coverage, one agent alone should be fine. So probably the next guidelines will consider this, but since these were a while ago, it's probably not necessary to do 2 agents. And this study reviewed ceftolozane tazobactam, which is kind of the newer agent that Christie didn't cover. And the reason is it doesn't add anything for CRE, but it does add Pseudomonas coverage. So it is something to consider for carbapenem resistant Pseudomonas, ceftolozane tazobactam. And there was no difference when you looked at combination therapy versus monotherapy. So for Pseudomonas that's resistant to carbapenems, traditional beta-lactams can be used and can be used in dose optimized fashion. These are from the guidelines that hit last week, so check them out. Difficult to treat Pseudomonas, they have a definition for, so that's resistance to basically all the things we would normally use first line. So piptazo, ceftazidime, cefepime, carbapenems, and quinolones. And so they recommend that you can use ceftolozane tazobactam, ceftazidime avibactam, or imipenem relebactam. And you'll notice that one thing's missing here, probably the biggest thing, is meropenem vaerbactam. And we already said that's really not the, KPC isn't the mechanism of resistance. So meropenem vaerbactam probably won't add anything for your Pseudomonas. All right, treatment. Duration for Pseudomonas. So that's another kind of controversy in the gram-negative space, I would say, that's not exactly settled. So the 2016 HAPVAP guidelines recommend 7 days kind of across the board. But they do have this quote in the subgroup of VAP patients who had a lactose fermenting gram-negative rod, such as Pseudomonas and Acinetobacter. They were associated with more recurrent infections. So there was a discussion for Pseudomonas bloodstream infections, how long is long enough? And they compared 10 days versus 14 days. And this was fortunately came out after the guidelines in 2019. And about 10 days was similar in outcomes to 14 days. So perhaps 10 days is a magic number, but I would say it's still a bit up for debate if 7 days is appropriate, which is laid out again further in this slide. So this was kind of the discussion paper that prompted a lot of for Pseudomonas treatment is 7 days enough? And they went through 3 different studies in this discussion paper. I would read the whole thing. It's very good, laid out very nicely. So they have 3 studies that have 8 versus 15 days for HAPVAP. And the first one, they had 120 Pseudomonas isolates, and they did have higher recurrence in the Pseudomonas group. In the second study, they didn't have patients who had non-lactose fermenters at the time of randomization, so it's not applicable. And then in the third study, they discuss there were, it was a prospective randomized control trial, which is amazing, but unfortunately it was stopped early due to inclusion rate. But it failed to show that 7 was equivalent to, or 8 was equivalent to 15 days for Pseudomonas VAP. So potentially this is kind of our gap in therapy for durations. 7 versus 14 is likely fine for most Enterobacterales, but Pseudomonas, it's not quite as clear, and guidelines will likely revisit this, but don't exactly address it at the time. Okay, in summary, probably a single agent is fine, despite what the older guidelines say, and then also the older guidelines say 7 is fine, but maybe you want to consider 10 to 14 days, or watch your patients really carefully if you're going to do 7. If they look like they're doing great on day 1 or 2 and it's uncomplicated, it's probably fine, but consider 10 to 14 days longer course for Pseudomonas. Okay, we've got a few other things. We kind of piled everything into the gram negatives, so bear with me. So aminoglycosides, I'm going to give you a quick rundown because pharmacy, we love to talk about PK. And these are just options to consider for severe gram-negative infections when you're struggling to find a good option, tips and tricks to get around resistance, optimize dosing. Okay, so Pseudomonas, hopefully you guys are all aware, the CLSI breakpoint changed this year, and it was kind of a big change. So Pseudomonas, less change for things like amikacin, but gentamicin no longer has an interpretation. So that's going to look different. And everything really has dropped for Enterobacterales. So amikacin went from 16 to 4, which if you've seen a lot of the isolates, that's probably going to be a lot of patients. So if you haven't seen this yet, your antibiograms will likely change once they get incorporated. Does anyone use the single dose aminoglycoside for UTI? One taker. All right. Well, let me convince you guys. Very good. So this is good if you don't have any options. So if you have an ESBL and Bactrim and Cipro are resistant and you don't want to give them a PICC line, that's a consideration. That's a big commitment to give someone a PICC line. So we've got peak over MIC, AUC over MIC, and time over MIC. So concentration time curve, our aminoglycosides act with a high peak ideally 10 times the MIC over the organism is associated with optimal killing. So fortunately, as Christie mentioned as well, aminoglycosides can reach 100-fold within an hour of administration concentration compared to the bloodstream. So if your bloodstream concentration is 10, you're getting way higher. I mean, way higher than you would ever need to kill the organism. So it's something to consider, especially if your breakpoints have dropped, but they're still in a reasonable range. If the patient is improved, they're already gotten 2 to 3 days of meropenem, for example, maybe giving them a dose to finish out the course would be reasonable instead of an IV. And then it also remains therapeutic, so it gets sort of redistributed back into the urine in the kidneys. So it lasts for a long time at the site of action. Something to consider. There is also clinical data. So in summary, patients do have really good results. So this was a systematic review. A lot of this was older data that was included because it was tried more frequently, and then we had newer agents. So some of it's old, some of it's new with the single dose aminoglycoside for UTIs. But a lot of it, so in results, there's 95% microbiological cure, and then sustained cure at 30 days was 73%, with very low toxicity overall reported in these studies. So here's my recommendation. It's unlikely to be nephrotoxic with a single dose, though of course you'd want to weigh risk and benefit, though you can give lower doses for things like UTI. You don't need to slam them with a really big dose. And then consider risk versus benefit of a PICC line. It's time in the hospital, it's time to get nursing to come place it and get them discharged, also inconvenient for the patient. So I would consider it absolutely for patients on day 3 instead of putting in a PICC line to finish out a 5 to 7 day course, depending on the patient. Okay, hopefully you guys were just at this oral presentation. So Dr. Cynthia Nguyen covered a lot of, gram-negative type with the first half of her presentation, but I'm just going to reiterate it just briefly. So we're going to back it up. So as opposed to aminoglycosides, our goal with cephalosporins is time over MIC. So we want to maximize the amount of the day that we can have therapeutic concentrations over the MIC of the organism at the site of infection. So here's the CLSI, and I think some people don't realize that cefazolin should be used as the breakpoint for ceftonir and cephalexin oral cephalosporins instead of ceftriaxone. So that's something to keep in mind, that you should be using cefazolin instead of ceftriaxone if you're looking at ceftonir, cefpodoxime, or cefixime. So that's something to consider. So here is a patient example. We've got a cefazolin that the MIC was 4. So we're going to do some math. Let's say that we have ceftonir 600 milligrams and our peak concentration is 2.87. We'll round up to 2 for a half-life to be very, very generous. And we're going to compare it to Keflex, which is 1,000 milligrams, and our peak is 30. You'll notice 10 times higher, and the half-life is 1 hour. Okay, so we dose ceftonir once a day, and it never reaches the MIC. So this is what I think Cynthia was referring to as placebo. So this is kind of why, if we can ever use Keflex for almost anything, it's just going to get a lot better exposure overall. So that's, if you talk to your pharmacist, probably why they're pushing you towards Keflex and away from ceftonir. Some of the other 3rd generation cephalosporins aren't quite this bad. They have higher peak concentrations, but not nearly as high as cephalexin. So this is my cephalexin speech. Please use it whenever possible. It's probably going to be better. Okay, treatment duration for gram-negatives. So we've got, hopefully you all have seen, there's been several 7 versus 14 days for gram-negative bacteremia. So they put them all into a systematic review and meta-analysis. So we've got 3 randomized control trials with over 1,000 patients with Enterobacterales bacteremia. So they looked at 30 and 90-day mortality, relapse, length of stay, readmission, and complications. And in the end, no difference in any of the clinical outcomes. So I know we're somewhat hesitant to use it in all situations, which of course, source control, the source of infection, where is it coming from? But really there's extreme mounting evidence, enough for a randomized or for a meta-analysis, that we really should be using 7 days instead of 14 days for gram-negative bacteremia. Was that me?
Has it been like that all the time?
Just making sure you guys are awake. We're almost there. We're getting so close. Okay, so I feel like we got partway there with Cynthia's presentation, but I did include 2 studies that looked at pyelonephritis and oral cephalosporins, because I think this is a question that we get, and that people tend to use things like fluoroquinolones and trimethoprim sulfamethoxazole for, which is great if that's appropriate. But I think we should have another push for Keflex. So there was the left one, which is Lynn 2022, and then the right one, FASA 2022. These are 2, they're retrospective cohort reviews, so have all the issues that they always do, but a little bit of evidence that cephalosporins probably fine. So the first one is just compared to fluoroquinolones, and then the second one is compared to either quinolone or trimsulfa, and both had equivalent outcomes. So they looked at, the outcomes are a little bit different, but kind of similar: treatment failure or UTI recurrence at 30 days, and there was no difference between the 2. And they do include the cephalosporins, so I put them underneath. So Keflex was the predominant really for both, but then they included one had ceftonir, dang it. But most of it was cefodoxime, cefuroxime, and cephalexin. So that was primarily for both of these. So pretty good data that we can likely use cephalosporins, and then just make sure you're dosing it really well for your patients. Don't be afraid to give them a gram. Okay. So bradspellberg.com/shorter is better. So this is taken from his 2016 review article in JAMA, but basically continues to be mounting evidence for sort of every time we study it, they're just as good, shorter versus long durations. So most of these are relevant for gram-negative infections. So we've got pyelonephritis here, intra-abdominal infections, HAP-VAP, and skin and soft tissue. So generally, we're getting to the point where shorter is better. They can decrease length of stay and patient outcomes like Idph. So shorter is better. Just wanted to plug that. But a lot of these are gram-negative infections, pyelo. We really can be using shorter courses. Okay. So in summary, tips and tricks: aminoglycosides, I would consider it if it's going to save your patient a PICC line. There's lots of risks with IV therapy. Oral cephalosporins, they're not all the same. So Keflex if you can, but just try to avoid ceftonir. It's probably the least good for PK. And then gram-negative infection durations, equivalent outcomes between short and long. There's really not much data that longer is better, but you can reference all of the many prospective clinical trials on that. Okay, we're going to talk about crab. Okay, who all has crab in their patient hospital setting? Okay, yeah, it's a big problem across the board. It's, likely one of the biggest carbapenem resistant things that we see. Is it real? Is it not? Is kind of the biggest question, but it ends up in a lot of places: long-term care, inpatient, outpatient, unfortunately. So the IDSA guidelines were just updated last week, and they have great recommendations. So one of the reasons it's so difficult to treat is that it has some of these really scary metallobatolactamases and very difficult to treat mechanisms. So there's no clear standard, but what they do really recommend is make sure it's real. So the drugs that we use to treat it may or may not be super helpful if it's, if it's just colonizing. So that's number one that they recommend in the guidelines, make sure it's real. And they don't really have strong recommendations for what to use because it's really hard to do a crab trial when there's not a lot of agents that cover it, and standard for diagnosing an actual infection versus colonization. So they do recommend to do dual therapy, but they only had 1 out of 8 trials found improved outcomes with dual therapy, but they recommend it anyway. So I would say take that with a grain of salt, whether you want to double cover or not, if it's a susceptible organism to a single agent. And they do recommend to use Amsulbactam, i.e. just Sulbactam, across the board. Even when non-susceptibility is demonstrated, they recommend to use the very high dose Amsulbactam, which is 9 grams every 8 hours. So very high doses. And then additional agents that you can add on: minocycline, tigecycline, ceftriaxone, or polymyxin B. Okay, so this was just recently approved. And there is a new treatment for crab. It apparently isn't available yet, though it should be hitting the buyers soon. Whether you can do susceptibility testing or not probably will come later. So there's going to be all the issues with the new agent, but we do have a new agent, which is really exciting, which is Sulbactam durlobactam. So that was approved a few weeks ago, and it did have the trial that led to approval was for VAP or bacteremia, and it was for crab, and it was Sulbactam, durlobactam, or colistin on top of imipenem. So everyone got a carbapenem, and then they added this agent on. So keep that in mind. It wasn't studied monotherapy. Unclear if you'll need it with imipenem, but that's how it was studied. And they actually showed the results are pretty compelling, that if you have a serious infection with crab, you probably should use it over colistin, which maybe isn't surprising to anyone, but I think is something to really consider. These things are expensive. It's going to be expensive, but if you have much better mortality outcomes, you should probably use it. Okay. Takeaways. We've reached the end. So each of the newer agents has a niche. They're not interchangeable. It depends if you're treating Pseudomonas or CRE or crab. They're not the same. So just look at the guidelines are really, really good. The 2023 updated guidelines. So please, if you see a resistance pattern, please check it out. And then optimizing PK can help you get around some tricky resistance patterns. Shorter is better. PO is the new IV. And any questions? Thank you. There's always something in time.
Yeah, that's a really good question and something the guidelines didn't specifically address, but the thought was that giving more aztreonam would potentially help target that MBL a little bit better. So if you're doing the Q6 and the Q8, I would probably try and stack them as close together as possible. But knowing once you reach steady state, hopefully you should have a steady infusion of both drugs, so it probably doesn't matter as much. But initially, I would try and time them around the same time. Yeah, good question.
Talked a lot about treating the infection, but what do you guys think of like the vaccine, like the infected site drug that we're growing?
Yeah, the question was related to methenamine, particularly I'm sure for urinary tract infections. There is some data, and we do use it in our kidney transplant patients at Northwestern Medicine quite a bit. The thought is that it's a non-antibiotic approach to try and prevent recurrent urinary tract infections. So we do use it in some patients, and I think it is a good option if you're kind of weighing the risks versus benefit of starting them on an antibiotic as long-term prophylaxis versus methenamine, and having that discussion with the provider. I think that's a good option.
Better than antibiotic prophylaxis.
Yes. Great.
Worth a try.
Well, thank you all for your attention at the end of the day. We appreciate it.
Made it through.